Guys, what's up? I'm back. Video number 3 today. I'm going to go over elbow eval and special test, mostly because it's the exercise, or I should say the special tests that I do are a little different than what you would see in a clinic or learning in a classroom setting if you're coming out of a KD accredited. Now, let me say it's not a knock at all whatsoever. The special tests that you guys are learning in the classroom, I learned them as well. It's a great foundation to start off with, and then the more you do them, the better you get at them, and then also you can develop your own way of doing things. Like, just over the years, I've developed a way to kind of narrow it down, and within a few special tests, I can figure out what's going on. That's because I've been doing this for a while. I've done quite a few elbow evals. But the other side of it is, like, a lot of the other the special tests that I do, they're tricks of the trade. You know, you really only see them when you're out working in baseball and you're in the baseball setting. You really only see them there. You don't really see them anywhere else, or unless you're around a clinician that has been in baseball before for several years. So aside, when you're getting ready to do an eval, and aside from the questions that you ask guys about, what had happened, have you had any issues with this in the past, is this the first time, did it kind of just come up on you, or was it an acute issue? Most the common questions I ask is, the first one I ask is there a certain pitch that bothers you on? Because you typically don't see this in a flat ground session or when the guys are just going through their normal throwing program. And if it does, and you talk to the guys, the first thing they're going to mention was, well, the other day I was on the mound and that's when I really started feeling it. So if you're seeing a common theme here, it's guys being on the mound. And that's the reason why the UCL rears his head there, is just because they're on a slant and the guys are throwing as hard as they can, and they're doing multiple pitches and all that type of stuff. So that's when you see it. Most commonly that I see is on the curveball. Now, the reason why is because of hand positioning. Every pitch, for the exception of, on my head, is a slider. The hand positioning is different. Your fastball, you hear guys, you want them to stay behind it. So when they're throwing, they're right here behind it. It's kind of the same thing with a slider a little bit, except you got to kind of cut it a little bit. But for the most part, you're staying behind. Change up, you're right here, and the ball sits real deep in your hand, and you've got the circle right here, and then you're kind of staying off of it, and then you're kind of coming off to the side. So there's not a whole lot of stress on that one, partly because of that, and then the other part is because the velocity on a changeup is significantly lower than it is on a fastball. Now, the reason why on a curveball, and this is why you'll hear me say it, it's like for younger kids not to throw a curveball. It's because of the stresses that it places on the elbow, because unlike the fastball where you're behind it, the curveball is right here, is you grip it here on the seams, or you do a spike, and you turn your hand this way, and you're coming this way, okay? So you're already putting stresses on your elbow, because the whole idea of is that you can't stay behind a curveball when you throw it. You've got to come up over it and then snap down and get this motion here. So this motion to get that spin. Now, when you put them on a elevated plane, and then all of a sudden it goes downhill and it drops almost a foot by the time they land, the stresses of going downhill plus the stresses of them trying to go up and over, going against gravity, there's only the stresses have to come out in one spot, and biomechanically it's over the UCL. So that's typically why you see a lot of it in the curveball. Another question to ask is, at any point in their release, some guys will feel it when they're like right here going forward. Some of them will say that they feel it on their release, or very few will say that they feel it on their follow through. So that's another one. Another big one is, at any point do you feel any type of numbness in your elbow, in the medial side over the sublime tubercle. Sublime tubercle, for those if you're wondering, it's essentially, if you know where your funny bone is and you've ever hit your funny bone, guess what? That's your sublime tubercle. That's where the ulnar nerve runs really shallow, and that's where you typically feel that. Guys will it'll feel tingly, or it'll just get numb in that area right in there. That's another telltale sign. You can also ask them, has this been going on? Because a lot of times guys won't really say anything whatsoever. They'll kind of just go with it, and then when they get to the point where they can't take it anymore, they'll be like, all right, my elbow kills. Or did it just start? Some guys, it just started like a couple days ago. It happens. That's just how the body is. So those are a few things that I look at. Now actually getting into the eval portion. For me, when I take my guys in to see my physicians, if I know it's something serious, like really serious, to where I'm going to need imaging, the first thing, and I mean the first thing he's going to check, shoulder, and he's going to look at GIRD, GHIRD, glenohumeral internal rotation deficiency. That's the first thing he's going to look at. And if my guy barely moves internally, he's going to give me a look, because he knows that I should know better, and I do. And some guys will slip through the cracks, but that's the first thing he's going to look for. So that's why in my previous post I had talked about stretching, because it's in the screenings it tells us what we already know. Guys are internally tight. We already know that. But it's been proven that there's a correlation between a tight shoulder and elbow issues. So until studies prove that otherwise, we're going to keep going with it, because all this time studies have proven that. So it's a common denominator. So in the eval, I get the guys on the table. I have them sit there at the edge. The first thing I'm going to tell them to do is, and we all do it, you sit on the edge of the table and you slouch, right? So the first thing I do is sit up straight. Just have them sit up straight and keep that there. Why? Because this is almost similar in the throwing position. Their core is upright. We try and keep them from getting here. Some guys will do it, but most guys don't. We want them up here. So I want to try and simulate them being there. The common one that guys will, or that you learn in class, is the tenalis. It's just tapping over the sublime tubercle. Some guys will get just a cold shot down into their ring and their pinky fingers. Well, that's red flag number one. So I do that one. The common one that I learned in school, and that I still do it now, and I've seen it in pro ball, is just your seated valgus. Just grabbing their forearm, and I tell my guys, hey, just lightly squeeze the inside of my arm, and they squeeze, and all right, now just relax it and hold on to my elbow, or hold on my biceps and inside of my arm, and then I grab from the outside and I push, and then I just twist and I move it in and there. That'll usually light guys up. Be careful of that one, because guys can compensate a little bit, and they can kind of go in here, and then they start doing this, and then compensates, and you don't get a really good reading. So keep an eye out for that. That's the common one. The other one that I tell people is, while you're grabbing there, you want to keep your thumb or your fingers over the sublime tubercle, and when you're moving them, feel for the ulnar nerve. Sometimes you can get the ulnar nerve to sublux, okay, and you'll feel, it's just like when you're doing the meniscus test, you feel a little flick underneath the skin. The same concept. You'll feel the ulnar nerve moving around in that groove, okay. So look for that as well. Force flexion here, okay. Force flexion and the balance home. I call it bang home. That's just for me, because I'm banging the elbow. Force flexion and force extension stress the UCL. Okay, so that's why in the weight room you don't see us doing cleans, because when you go here and then you have a bar pulling down, it stresses the UCL. So that's why we don't do it. But it's a really good special test, okay? Because when you close, The forces from pushing this way, they got to come out somewhere. So they're going to come out the sides. And the UCL is the most common spot for it to come out. So you'll have that. The milking maneuver, it's kind of just like how it is. You just bring them out here, come from the back, grab their thumb, and then just pull back, and just lightly pull back on them. That'll usually get guys, but you need to be careful with that because guys can compensate for that. They can go into thoracic extension because that's what they do. That's what pitchers do. They're able to go pretty far back, so you can get a distorted reading on that. So keep an eye out for that. That's the other reason why I'm kind of not a fan on it. But I've done it enough to where I know how much force I can pull or I can put on the guys before I start getting them into thoracic extension. So that's another one that you can do. Another one from there is just grab the two fingers and pull them back, and that's one way to kind of see if the flexor mass is involved as well. Is doing that one. So those are the ones that I kind of do sitting up. Then I'll move them lying down on their back, and I'll still do the milking maneuver one. That's where I can actually get them and I can crank on that because they can't really go back into extension because they're on the table, so they can't really compensate. So I'll take them into the milking maneuver here and just move them straight through here while I'm grabbing the thumb and pulling it back, and I'm still bracing on the elbow here and moving them back. Okay, so I'll do that one. Then kind of like how I said on the last one, to see if flexor mass is involved as well, I'll grab the fastball fingers, these two, and I'll do the same thing and I'll pull, and I'll just go into a stretch. And if guys, if the flexor mass really isn't involved, they'll just say, it kind of feels like a stretch. And then I'll grab all four, kind of the same thing. That one, it'll light them up a little more because you're pulling on the fourth and fifth, and we all know the ulnar nerve goes down into the fourth and fifth. So you'll see that one as well. That one is probably one of my favorite ones to do. The other one, I don't really have a name for it. I saw it when I was working in pro ball years back, and it's another one of my favorites where they're lying on their back, and I'll just bring them right here, and I'll push from the outside here, and then I'll take, and so if they're lying down, I've got their elbow here. I take my left hand, I'll push, and then I'll just move them into flexion extension, and they'll be out here in a 90-90. And they're going here, kind of like a tomahawk. I'll take that one to that one. They can't really compensate for that one either, but I'll let them on that one because here's the thing. I've got the elbow pinned, and they can keep going this way. It's only going to make it worse for them if they do it. So, they'll want one of those that they'll let you know right off the bat. Probably my favorite one is this next one. From there, I'll tell them, hey, turn onto your stomach. Lay down, scoot over to the edge of the table. If they're right-handed, so they'll be down prone 90-90. I will take my leg and I'll put it on the leg of the table. Kind of, if you're in the athletic training room, you know exactly what I'm talking about. How some of those treatment tables have that shelf down on the bottom, and in between the two legs, there's that bar that goes across. I put my foot right there. I pin their elbow down between my hand and their knee, and I grab the hand and I crank on it. And if a guy's got a UCL issue, he'll let you know right off the bat when you're doing that. And if not really, like if you get them here at 90-90 and you crank and you're pulling on and they're like, a little bit, take them through the moving valgus. At that point, if they've got a UCL, they'll let you know. That's my favorite one right there because, if a guy doesn't really have one, I can tell right there because, like I said, I can really crank on that elbow. Just by pinning it down here and then pulling it and taking it through. I can really tell from that one because I'm putting a lot of stress on that elbow. Some people think it's, why would you do that? Well, you'd be surprised. You get into an OR and you see some surgeons, they're not really delicate when they get in there. They'll get in there, and they go to work. So you'd be surprised that how much they can handle for it. Plus the other side of it is once you start doing it and it really bothers them, they'll let you know. Plus, like I said, I've been doing this for a while, so I know exactly how much pressure and stress to put, just because, I know my guys, and two, I know the threshold that I can go. And then the final one is just have them stand up, tell them get into your throwing stance, your throwing stride out, okay? Arm out into scaption, aka your arm slot. So if you tell them scaption and they're like, what? Just tell them arm slot. Oh, and then they'll go right out here. And then you just come up and essentially high five them and tell them, hey, throw. And they'll go through the throwing, and it'll light them up, depending upon on where it is. If some guys will say, I'm out right here, like it bothers me out here. Cool. Just tell them, get in your throwing stance, put your arm there, and then you essentially kind of just high five them, and you provide resistance and tell them, all right, go through your throwing motion, and they'll try, and it'll light them up right off the bat. So that's another one of my favorites to do as well, having them stand up. I will put out a video, probably I'll try and work on it tomorrow, of the videos of these actual tests themselves, how I do them. So you can kind of get an actual visual of what I'm doing and how I'm doing it. But just, I guess, a few key points on this one is I was told this one very early on, and to me, it's still stuck to this day because it's true. Even my physicians, they go by it as well. Always assume it is UCL until proven otherwise. And by that, I mean an MRI, okay? So if you don't get an MRI, you just automatically assume it's a UCL. Even if they're pointing flexor mass, whatever, UCL. Because here's the thing. If it's a flexor strain, guess what? You're going to treat it the same way. The protocol is essentially the same, okay? So you just treat it that way. That's the mindset you need to have, is that you're going to treat it like it's a UCL. The other one is look at their mechanics. Pitchers are creatures of habit, okay? As are just baseball players in general. I'll put money on this. Baseball players more so than any other athletes for any other sports, because baseball players, and I say we because I'm there with them, but we do the same thing over and over and over every single day. And baseball, to me, is essentially the definition of insanity. You do the same thing over and over and over and expect different results, which if you've been in pro ball before or you've been around it, you see that they do the same thing every day, expecting to get different results. Oh, the guy's not hitting well, go hit more. Or oh, he can't get a ground ball, take more ground balls. I mean, to an extent. So, with that being said, look at their mechanics. That'll be the first thing that should be a flag for you guys. If you see if a guy's dropping his arm slot, if he's normally a guy up here and all of a sudden he drops his arm slot down, that should be another red flag that you should look at, because pitchers are not going to change their mechanics just to change them. They're going to change them because something hurts. So they're going to try and find an arm path or an arm slot that does not hurt them. So that's why, I'll sit out there and I'll watch the throwing programs of the guys, so I can get a mental note of what is normal for them. Because then if I go out there one day and I see them, and it's happened where I've seen guys change their arm slots, and I'm like, all right, something's going on. Or my pitching coach will come and tell me, hey, so-and-so, they've changed the way they've thrown. Like, they're the best ones to go and talk to, because they know exactly how these guys function. So I'll keep an eye out for that as well, just to see what they've got. One that I just started seeing recently, and I never really saw it up until recently, is an acute UCL. I've had a couple where they've just off a throw, just a single throw, felt a pop. So the common things that you'll here's a couple common things that you'll hear them say is that I made a throw, I felt the pop, and it went numb. And by numb I mean right here over the UCL and the kind of the medial elbow. They'll say it went numb for a little bit and it's come back now. That's the most common one, is that it went numb. The second one is that hey, I tried throwing and my elbow just feels really funny. They'll they'll know, because it's just like I said, it's a commonality for these guys. They do something every single day, and they get fairly in tune with their arms. Not necessarily in tune with their body, but in tune with their arms. So they'll tell you, hey, it's feeling kind of funny, and I don't know what it is. So they'll tell you that. So I know I threw a lot at you in about 21 minutes, but if you got any questions, shoot me a message on Instagram, Upper Deck Sports Medicine. I'll help you guys out there. Plus, like I said, I'll work on it tomorrow where I'll get a video of all these special tests, how I do them, and then I'll post them as well so you can see this as well. And then after that one, I'll go into shoulder. Shoulders, there's not a whole lot different of special tests that you do. It's more so I'm looking at different things around the shoulder, like the shoulder girdle, scap, that type of thing. So I'm kind of looking at those versus actual special tests of the shoulder. So we'll go from there. But I hope you guys enjoyed it. Hope it was helpful, and hopefully I made myself fairly clear to the point where you kind of have an idea of what I was trying to portray until I get these videos out. But otherwise, guys, stay safe out there. Spend some time with your family. Stay indoors and do your thing, and then keep an eye out for the upcoming videos here within the next day or so. Appreciate it.